Okay, can everybody see that?
Yes, Prof. We can
Good.
see the screen.
Good, good. Okay, so we're going to talk about endocrinology today. And so we're going to, obviously it's going to be primarily sort of thyroid and parathyroid, but I'm going to cover a few other organs towards the end. So just goes to work. So we can talk thyroid, parathyroids, a bit on adrenals and stuff on sort of tracers and relationships to patient pathways, etc., and something about how we can contribute to management and treatment. So nuclear medicine, actually, if you remember back, well, not actually remember, but if you've read it, even I can't remember when it started, as it was the 1940s, and I'm not that old. It really started with endocrinology, and particularly with thyroid disease. In the early 1940s, a place called Berkeley in California were producing iodine 131 and iodine 130 using a cyclotron. And very quickly, physicians worked out that it could have uptake in thyroid. And this is the first patient we know who received radioiodine, who was a Japanese-American girl who was treated for hypothyroidism with radioiodine in the early 1940s, and she lived to the ripe old age of 89, so proves it works quite well. So the aim of nuclear medicine now is to track physiological actions using the tracer principle, and endocrinology is probably in one of its purest forms, because what we're really doing is exploiting the body's endocrine functions to identify what's happening with that particular endocrine gland. So we're primarily physiological, but obviously we can infer some anatomical information, and then using techniques like SPECT-CT, it may be possible to improve that localization. So we all know where the thyroid gland is. It's sort of, we describe it as a butterfly-shaped organ, lying just below the thyroid cartilage and in front of the trachea. And it has two lobes and a central part called an isthmus, which is a geographical term for a bit between two islands. The isthmus is of variable size in the thyroid. Sometimes it's quite large, sometimes basically non-existent. And it's a classic example of what we call a negative feedback system. So we have the pituitary, and that produces the TRH, which is the releasing hormone, which then releases the thyroid stimulating hormone, TSH, which then goes down to the thyroid. And the thyroid then releases thyroxine, mainly as T4, but also some T3, and that depends on the number of iodines attached to the thyroxine molecule. And as the levels of T3 and T4 in the blood increase, so the drive to release TSH is reduced. And so it's meant to be always in balance. Now, obviously, sometimes that balance is affected by thyroid disease, which means actually the measurement of this TSH is often a very good marker of what's actually happening in the thyroid. The thyroid gland itself contains interesting structure. It has these follicles, and within each of these follicles is this colloid, which is a sort of glycoprotein which contains the sort of primitive thyroxine. And at the time, this thyroxine often has only one or two iodines attached to it. But when stimulated, it will be iodinated by the follicular cells and then released into the blood. Now, in patients who have very poor iodine intake, they can build up quite a lot of this colloid because it's not released, and that can result in a goiter. Sorry, it's just... So the actual release mechanism itself. So as we said, in the colloid we have this often labeled, iodine labeled thyroxine. And when you get the stimulation to release it comes in, what happens is that this is then converted into T3 and T4 and then excreted. And this is done by a sodium ATPase dependent pump, which also brings in the iodine. And that is, we know, we call that the sodium iodine symporter. And because it was discovered in Germany, and the German for sodium is natrium, it's known as the NIS system, and we talk about the NIS gene. So that's the sort of cycle of iodine within the cell. So thyroid imaging, when should we do it? How does it help with diagnosis? Are there other alternatives? And what happens after treatment? So most organs can only do three things. They can either be too active, not active enough, or they can get some form of malignancy that could be benign or sort of tumor, benign or malignant. Benign lesions that are not active, we tend not to worry about so much, but obviously malignant ones we do. So in terms of scan preparation, there's a little bit of preparation that may be required, particularly in patients who have hyperthyroidism, in the fact that these patients are very rarely scanned before they're treated because they are diagnosed essentially using a blood test out in the community, and they're often started on antithyroid medication. So we need to send them a letter, and that letter will contain instructions to stop antithyroid drugs for at least 48 hours. In my center, we prefer 72. Some centers are a bit more draconian and pick 1 week. That's okay as long as the patient doesn't have significant Graves' disease, because they can become quite ill, especially if you can't give them beta blocker cover because they have asthma or something. We may be, if we're scanning patients with thyroid cancer on thyroid replacement hormone and we're using withdrawal, then thyroxine needs to be drawn for at least 4 weeks, and T3 3 weeks. Some people are slightly less worried about 3 weeks and may reduce that to about 10 days, but you certainly need to make sure that that's withdrawn. However, as we'll show later, quite often we can use recombinant TSH now, which avoids having to do that, particularly in private practice. That's very useful, where patients can pay for the recombinant TSH. So as we know, thyroid hormone itself can affect uptake because it knocks off the TSH drive, which is used to drive in the radiopharmaceutical. Medication, as we said, antithyroid drugs, but also anything with a significant iodine load. And the problem is that certain things like radiological contrast agents result in a very significant iodine load that really is not physiological. And traditionally we say have to wait 6 to 8 weeks, but I've had patients who've had a blocked thyroid drug for a year after being given radiological contrast agents. Things like CALP products. Now, the point is the patient may not know they're taking these. So there are many different sort of, in quotes, herbal cures for thyroid disease, which people may purchase or be given. And these can contain quite high amounts of iodine-containing products, of which seaweed-based products are the highest. And South Africa is the second highest producer of kelp products after Japan, so maybe more common in South Africa. So you do have to ask not just about prescribed medicines, but if people are taking any form of other medication that they're taking from things like health food shops or friends and neighbors. And then there's the famous drug amiodarone. I have to say I myself have had amiodarone. It's not a pleasant drug to take, really, and that can affect the thyroid in strange ways. Sometimes it increases uptake, sometimes it decreases uptake. And the most important thing is you need to talk to the patient. You'll only get this information by talking to them. So why do we use patentate? Well, patentate is used for thyroid scanning because basically it's cheap. I think we would all like to use an iodine if we could. Iodine 131 has a quite poor dosimetry and has moderately expensive. Iodine 123 has very good dosimetry but is very expensive. And the reason is all to do with charge and size. So at an atomic level, the technetium metal and 4 oxygens has about the same size and charge as an iodide charged element, and basically just fools the body. The body thinks that it's iodine, so it will be taken up by the same mechanism. Obviously, it won't be put into the thyroxine, and it tends to get released quite quickly afterwards, which is why we do the thyroid scans fairly quickly with the patentate. If you did a thyroid scan at 2 hours, for example, you'd find it all disappeared. As we said, it's the patentate is cheap. It's not what we call organophide. And we use about 80 megabecquerels, and we scan 15 to 20 minutes post-injection, and the scan we try to complete by around about 40 minutes. Iodine 123 is more expensive. You can scan up to the next day if you wish, and we can give it orally or IV at about 20 megabecquerels. And there are techniques where we measure how much we're given before and by measuring what we're given before and afterwards, and calculating how much that we've actually given the patient, and we can use this to calculate percentage uptake. We'd also need to know the camera sensitivity, and with patentate particularly, we need to have a decay correction as well. Doesn't really matter what kind of gamma camera you use, though. Strangely enough, the smaller, older gamma cameras tend to be a bit better because we can get them close to the patient's neck. Obviously, we use a standard parallel collimator, but we can use pinholes as well. And I like a pinhole for thyroids because I think it gets as much more information of the because it effectively enables you to sort of zoom in onto the thyroid itself without loss of too many counts. The patient lies on their back and their neck is extended slightly. Most of us have like little small cushions we can put behind the patient's neck so it's comfortable for them. You have to warn them, though, that the camera is going to come quite close to their head and neck, especially if they're a bit claustrophobic. An anterior view, normally including the salivary glands, because that's used as a sort of marker of where you are, is useful. Some obliques can help, and laterals. Also, particularly with a large goiter, it can be useful to use, take a pinhole off and use a large field of view. And then you come out the suprasternal notch with a cobalt marker, which can be useful to look at the extent of goiter. So this is a normal thyroid scan, and as I said, it looks a little bit like a butterfly. This patient doesn't have much of an isthmus, and you can see there's a marker there put on the suprasternal notch, and there's a couple of obliques as well, which just give you a little bit more information at each lobe. So we do this in hyperthyroidism. Now, unfortunately, hyper and hypothyroidism are very close words and can get confused sometimes, even in request forms. So it is important that you make sure that you get the right request form. And if, for example, you get a message that, there's a lot of people joining us now. If you get a message that the patient's on thyroxine and meant to have Graves' disease, you need to just double check which way they're going. So the causes, the most common cause is Graves' disease, which is there's an inflammatory cause. And then there's autonomous nodules, which are either solitary or multiple. Sometimes the multiple ones are called plumber's disease. And this is really a degenerative disease of the thyroid. And then there's sort of thyroid hormone leak that occurs in thyroiditis. Now, this was thought to be quite rare, but is in fact pretty common. And there are a lot of new drugs which seem to cause this. Exogenous thyroid hormone, of course, and that would include slimming drugs, again, not necessarily prescribed by a doctor, but could be given to people. And there are some rare things like some ovarian tumors, like stroma ovarian, that can release thyroxine. And then you can also have pituitary tumors as well, though they're rare. I've only seen one of those. So Graves' disease, the primary diagnosis by history examination, and you can do biochemistry and immunology, particularly looking for thyroid-stimulating antibodies, TRAbs. And the functional imaging is confirmatory and particularly can help if you're planning treatment. Also, if you suspect there's another pathology going on at the same time. And can be of particular use in patients who've had a history of nodules or previous surgery, and you want to know what's happening, particularly if they've had surgery for Graves' disease, and you want to know if it's recurrent. And if you're, as I said, if you're considering treatment with radioiodine. And as we know, it is an autoimmune disease. It's not a simple disease. There are at least 10 different antibodies that have been described. Some of these affect other organs, particularly the eyes. So you get the traditional staring eyes of Graves' disease. And unusually, when you have normal autoimmune disease, like you see in diabetes type 1, it results in glandular destruction. This is unusual. It results in glandular stimulation. And that's actually quite rare and almost unique to the thyroid. And the sort of symptoms can depend on what kind of antibodies are present. If they cross-react with something else, so you can get this pretibial myxedema, as I said, or you can get thyroid eye disease. But also, some people can be tolerant of a significant symptom. So, for example, can be tolerant of a very high resting heart rate, whilst others will feel really quite ill with quite minimal symptoms. It's more common in women than men, and it's most common between age 20 to 40, though it can occur anytime after the age 10 until 100, really. We know there's a certain genetic predisposition, but we don't really know exactly what it is. But we do know there's an association, in particular with things like type 1 diabetes. And about 50% of patients, when you search through, will have some form of family history. So 50% will be new mutations, effectively. So what basically happens is, as you know, thyroxine drives metabolic rate, so they will get increased metabolic rate, which results in weight loss. Often they get diarrhea, sweating, fast heart rate, palpitations, tremor, anxiety, and I said the immune effects as well. They also can get some proximal muscle wasting, which can be, men seem to complain of more than women. Now, of course, some women might like the weight loss to start with, but it soon becomes obvious that this is not a natural weight loss. And it can, again, be confused if patients are trying to lose weight, that they seem to find it easier to lose weight than they did in the past. If we do a scan, and then this is actually a parathyroid scan. It could be an iodine scan. I mean, they can look very similar with this. This one, you see the suprasternal notch marker. And what you see is a very homogeneous distribution of activity throughout the whole of the thyroid. And when you look at the uptake values, as shown in the next panel, they're often highly elevated. Now, again, this isn't in every patient. This will be in a younger patient. In older patients who have already got some degenerative changes in their thyroid, the uptake may not be quite as smooth. You may get sort of areas of uptake of increased and decreased uptake, but generally you get this sort of very smooth appearance. This is, again, a technician study. This thyroid is enlarged. You can see that it looks like a very fat butterfly. It's a butterfly that may have been drinking too much nectar and looks a bit chubby. It's got a much more obvious isthmus. And when you look at the uptake, now for parathyroid, you would have a normal range, hopefully, for your own department that you've worked out. Where this was taken, the normal ranges was 0.45 to 1.7. It tends to run between about 0.5 to 1.5%. Depending if you're doing 15 or 20-minute imaging, it can alter slightly. And it shouldn't be more than around about 1.7 in this hospital, and it's 24%. So I think we can guarantee that this is definitely higher. The number itself is not as useful as it could be with patentate. Iodine probably a little bit better. So it doesn't really predict the extent of disease, other than you know that a 24% is definitely very, very high, and therefore it's a very active Graves' disease, whilst if it was 2.5%, you'd know it's a less active Graves' disease. And this is the kind of patient you may want to give a little bit of carbimazole to before you treat with radioiodine, because they could be metabolizing so fast that they'll actually just metabolize the radioiodine through the system so quickly that they don't get a reasonable dose. Now, I often have arguments with endocrinologists who think it'd be a great idea to do a scan in hypothyroidism because I'd like to see the reduced uptake. But you're trying to explain that it's a functional method, and if you can't see anything, you can't see anything, and it's not really very useful. And it can be a real problem if you have nodules and in a patient who is hypothyroid, and really I would get them to just do an ultrasound. Thyroiditis, Hashimoto's thyroiditis, is again a very strange condition because this is another autoimmune disease, but one that causes tissue destruction, but can go through a hypothyroid phase and then go into hypothyroidism. And so depending on the time between you getting the request form and you doing the scan, it can change. So for example, when they see the endocrinologist, they may be hypothyroid. They send off a request form. You book them in maybe for a few weeks later. And when it comes to doing the scan, they now hypothyroid and you don't see anything. And that could be due to a Hashimoto's thyroiditis. So thyroiditis itself, as I said, was meant to be very rare. When I was at medical school, we were told we would only see 1 or 2 cases in our whole lifetime. And if you worked in the nuclear medicine department, you could see 1 or 2 cases in the average week, maybe an average day if you do enough thyroid scans. Sometimes known as Decoverance Thyroiditis, which in particular can be related to pain radiating to the ear, which is a very self-limiting disease of about 6 weeks. Now, in fact, nuclear medicine is really good at this because both iodine and patentate are not taken up in the acute phase, normally within the first 4 weeks, possibly 6 weeks of symptoms. So what we try and do is always scan these patients as quickly as possible because if you wait too long, then they'll get back to normal. You won't know what they had. I said the patient is initially toxic, and then they get this reduced uptake on the scan. But by 12 weeks, in most patients with a subacute thyroiditis, they will get back to normal. Now, it is very important because some endocrinologists say that you can treat patients with iodine 131 just on blood tests alone. But the blood tests in thyroiditis can look like Graves' disease. And the problem is that then you'd be giving radioiodine for patients who actually got thyroiditis, which is not a good idea. So I always would scan a patient before treating just to make sure they don't have thyroiditis. And there are lots of these new drugs which are used in things like dermatology, mTOR inhibitors particularly, some of which seem to cause a thyroiditis. This is a nice picture of thyroiditis, and you can see the suprasternal notch, and that's just it. There's nothing else. And here's another one. This is a large field of view image, and this is why it's quite useful to have the salivary glands in the field of view, because that gives you some marker that you know where you are, and you can clearly see that you've got the thyroid bed there and there's no uptake, and that is as diagnostic as you can get. What about nodules? Well, women seem to suffer them more than men, and they increase with age. Most of these are non-functioning, and most of the non-functioning are benign. There is a sort of dependency on where you are in the world, whether or not that is true. The better the iodine in your diet, the less likely that a nodule, an active nodule, is malignant. So if you live near the sea, if you live in Durban or down in Cape Town, then the rate of malignancy is very, very low. If you live up in Gauteng, then it might be slightly higher, though of course you can eat a very good diet, including fish and things, which would avoid that happening, or maybe sushi, Now, I do need to warn you that most commercial sushi is not made at all with seaweed, but with cabbage, which has been ironed flat. So don't think if you eat sushi, you're going to get enough iodine. In some areas, particularly mountainous areas like the Himalayas and the Alps, the rate of thyroid cancer can be much higher, up to nearly 40%. So the way you manage these patients is very different in different parts of the world. And if you move from one part of the world to another, you have to learn what's actually happening in your part of the world. So to be honest, with any nodule that you're worried about, probably the best thing to do is an ultrasound and FNA. Now, nodules which are overactive, sometimes called hot nodules, less than 1% of these are malignant. It's extremely rare. So here we have a patient who has decided to have two diseases. This patient has Graves' disease. You can see the uptake is nearly 37% in a big thyroid, and on this side, on the left lobe, right in the interlobar region, there is a cold nodule. Now, this was unexpected because it wasn't really palpable, and this was a young patient. And if this patient, as they were, was 23 and female, you'd be very concerned that this patient has a coexistent thyroid cancer. So this patient does not get radioiodine. This patient gets a referral because obviously the easiest thing to do is surgery, which would obviously treat the Graves' disease and remove any potential thyroid cancer. And in a reasonable sized practice in my country, you will get an appearance like this 2 to 3 times a year. So we would see maybe 200 patients a year for treatment of hypothyroidism, and around about 1 to 2% of those will have a coexistent carcinoma. So, a cold nodule itself doesn't have to be a carcinoma. There are multiple other reasons. Colloid nodules, the most common. Cysts, just a straightforward adenoma, not an adenocarcinoma. Previous hemorrhage, something called focal thyroiditis, which can occur. Abscesses, well, patients tend to be symptomatic with that. A big parathyroid can make it look like that, and then obviously carcinoma, which tends to be one of the rarest. And for a active nodule, the only real cause is an adenoma. So again, we don't really understand what happens in a hot nodule. There basically is the degenerative disease of the thyroid, and what happens is you get release of thyroid hormone. The rest of the gland is suppressed, so you just see the area with increased uptake, and it's suppressed because the feedback mechanism drops TSH, but the adenoma no longer needs TSH to drive. If you have more than one, then sometimes it's called a Multi-Nodule of Goiter or plumber's disease. So here you have a nice big hot nodule with suppression, not complete suppression, but partial suppression of the rest of the gland. And this patient has a little bit more, common picture we see in more elderly patients where they may have more than one of these. So this is a multi-nodular goiter. In a way, it doesn't sort of matter because the treatment is always the same, which is radioiodine. Here's another patient with a multinodular goiter, and you can see that between the multiple nodules, there is no uptake in the normal thyroid. Many of these patients, if you catch them early enough and you treat them, the normal thyroid will just kick back and they won't need to be on thyroxine replacement in the future. So as we know, and I'm going to talk a little bit about this later, the main treatment we have for benign thyroid disease, and it doesn't really matter if it's Graves', toxic nodules or multinodular goiter, we prefer to give iodine between 400 and 600 megabecquerels. I very rarely in adults give less than 600 megabecquerels. You need to discuss the treatment with the patient. In the UK, we legally have to tell them about other options like surgery, and then they get informed consent, and particularly in Graves' disease about the risk of future hypothyroidism, and then radiation protection advice, of course. So when you treat an adenoma, it can be very successful. So here we have a patient who this is a very old scan. We have a patient who had a toxic nodule and was treated, and this was in the early days of nuclear medicine. We did follow-up scans, and you can see here very nicely that the nodule's no longer active and the normal thyroid has just come back to normal. So thyroid cancer is our next thing. There are two main types, papillary and follicular. And again, follicular is more common in areas which are iodine deficient. So you can work out the iodine deficiency in your area by the percentage of follicular cancers. Then there is this Hertel cell variant, which tends to be not very good at taking up radioiodine. And then medullary, which is to do with the calcitonin system. And anaplastics are very aggressive. And lymphoma should be counted. So again, we're going to discuss this in more detail. So the general way we get involved is in ablation therapy, and the idea is to remove all the thyroidal tissue, including any cancer cells, so that we can use the thyroglobulin to monitor patients. We tend not to give so much for the thyroid ablation between 1 and 3.7 gigabecquerels. And we repeat the treatments if we see any evidence of residual thyroid disease, or they still have an elevated thyroglobulin. And we may also be, even if the treatments are done by radiotherapy, we may be involved in the post-treatment scans. If you have very low uptake, you may want to consider scanning, and RD123 is preferable to RD131 if you can afford it. Remembering that radioiodine has no role in things like anaplastic tumors or lymphoma, except for obviously FDG. So here is a patient who has received their first treatment ablation dose, ablation dose, a 3.7 gigabecquerels of RD131, a whole body scan. Not only shows uptake in the thyroid bed, which is the big blob at the top, but you have multiple sites of uptake, and this is a stage 4 disease. Before they had this dose, they were told they had stage 1 disease, so it was a bit of a shock to them. So other traces that we can use for detecting thyroid cancer, particularly if iodine scan is negative, includes MIBI and tetraphosphamine, FDG, octreotide, something called DMSA5 or pentavalent DMSA, which we don't really use, and thallium, again, we no longer use. I'm just going to give you a couple of pictures. This is with octreotide showing uptake in the papillary thyroid cancer. Thyroid cancer can have quite significant somatostatin receptors, and some people have used lutetium or yttrium-90 dotatate to treat iodine-negative thyroid disease. This is FDG in a thyroid cancer. More commonly, what we do is we see uptake in the thyroid unexpectedly during a FDG scan for something else, and about 50% of these will prove to be due to tumor, so it's always worth investigating. And the main role is of FDG in thyroid cancer diagnostically will be in patients who have a raised thyroglobulin and a negative iodine scan. Medullary cell carcinoma of the thyroid is actually a neuroendocrine tumor, originally imaged with DMSA5, but more commonly now using MIBG, octreotide, dotatate maybe, but also, to be honest, is pretty good with FDG PET-CT. This is an MIBG scan of a patient with a medullary cell carcinoma of the thyroid. And this patient has received perchlorate, so their normal thyroid uptake is blocked. So what you're seeing is not thyroid uptake, but the medullary cell thyroid tumor. Just moving on to the other organs, parathyroids, big role of nuclear medicine here. Not in diagnosis, that's done by blood tests, but in localization to assist the surgeon in tumor identification, because if you can work out if it's an upper or lower parathyroid or left or right, it reduces surgical time very significantly, and also the surgical approach to avoid the recurrent laryngeal nerve. Sometimes used when for a second look if the calcium doesn't drop after an adenoma is removed. You can use ultrasound. It's readily available, no radiation dose, but needs to be done by somebody who's a real expert in parathyroids. Nuclear medicine, maybe not so commonly available. You still need to have some skill reading it, but the big advantage is we can look beyond the neck for ectopic parathyroids, and it's not affected by things like Multinational Goiter. So again, we look at the functional aspects of the tumor, and one of the problems is it's embedded in an organ which also has uptake of many tracers. So what we have to do is try and look at how we can remove the signal from the thyroid, and we can do that by subtraction or we can wait for the signal from the thyroid to wash out. So this is a subtraction technique. So we're using an agent we like MIBI with uptake in thyroid and parathyroid. And then we're doing a thyroid scan without moving the patient. So what you do is you do MIBI, scan the patient, keep them still, then inject the tracer for the thyroid, such as iodine 123 or technetate, wait 50 minutes, then rescan, subtract the two images, and you can see this is the iodine scan, this is the MIBI scan, this is a subtractive scan, and you can show the parathyroid adenoma. Much loved by physicists because it makes them seem important, because they have to do all the subtractions. Most of us now just use a washout technique, just using MIBI alone, because MIBI washes out of the thyroid at a much faster rate than does the parathyroid. So you can do your early image at 15 minutes, and just after 1 hour, the thyroid activity would have washed out, and then you can do the second washout image, and you can add SPECT or SPECT-CT, which improves localization. So here we have just a planar washout. This is actually a negative study, but it shows you how quickly the activity washes out from the thyroid. This is a SPECT study, and you can see here early on, you give it the thyroid activity, but this is now washed out, and you're left with your parathyroid adenoma. In this case, you can see it's a right lower adenoma, which is very easy. This is one which is ectopic. The parathyroids can occur in the chest. So this one's in the middle of the chest, and you can see that very nicely on a SPECT scan. But to be honest, it's even better on a SPECT-CT. And here we have an ectopic parathyroid sitting in the anterior mediastinum. And once you've got a SPECT-CT, these things become really quite easy. This is a non-ectopic parathyroid adenoma, and you can see it sitting very nicely behind the thyroid. There's the thyroid there. Now, on the CT of the thyroid, remember it contains iodine, so it contains its own contrast agent. So it's very easy to see. And once you've got the MIBI scan, you can easily see the parathyroid adenoma on the CT. Couldn't see it beforehand, but you can see it once you see it on the MIBI. And you can measure it, and you can give a very precise localization. If that doesn't work, some people have suggested using things like C11 methionine or fluoride FET, and now fluciclovine, which is normally used for prostate, may also be useful. This is a paper from Germany showing that in about 33 patients, there was very good uptake of these PET agents. Unfortunately, FDG is not useful, which is a problem if you don't have other agents available. And this is a patient of ours who had a negative MIBI. This is the SPECT MIB image, and this is the C11 methionine image. And you can see here a very small uptake. And this is because it was an absolute tiny adenoma. It was only 4 millimeters in the upper part of the chest. The adrenal glands, got two of those, one on the right, one on the left. As you know, when you're doing a PET-CT report, you've got to try and find them and make sure that they don't have any nodules in or got FDG uptake. The cortex produces various hormones based on cholesterol, and the medulla produces adrenaline and noradrenaline. So there's our friends. So the right-hand side looks like a bit like a sort of squashed man, and the left-hand side looks like a sort of Mercedes sign without the ring around it. So we have got some tracers. We can look at the adrenal cortex. Iodocholesterol has been used, and selenium norcholesterol, but the image quality is really appalling. And so we developed a product called C11 Metamodate with Uppsala University. Now, again, this is carbon 11 labeled, so it has some limited use, but there is a fluorinated product that's becoming available that would enable us to do this with fluorine. And this is a paper that was published by our center, looking at nearly 40 patients with a tumor of the adrenal called a Cons tumor, and this is a cause of aldosterone-driven hypertension. And we could show much higher uptake in sites of Cons tumor than normal metamodate. And this is a normal adrenal gland with metamodate, and you can see again very homogeneous uptake throughout the adrenals. This is a this is a 6 millimeter tumor with intense uptake of metamodate on the scan. So It's a very good way to find these kinds of tumours, but it is really a very specialist thing. But I thought I'd show you a nice picture. So adrenal medulla, the most common tumour is the pheochromocytoma. And these really, again, should be diagnosed not with nuclear medicine by looking at catecholamines in the urine. And the tracer here is meta-iodobenzoguanidine, which is a false transmitter, normally labeled with iodine 123, but you can get iodine 131. And it's taken up by a very specific amine transporter mechanism into this tissue. It's not specific to pheos. It can have uptake in some neuroendocrine tumors as well. You need to make sure the patient's not taking any drugs that can block uptake, which bizarrely includes cocaine and some beta blockers. Now, because it's iodine containing, you also need to give some thyroid blockade for radiation protection purposes. We normally use potassium iodide for that. If you're using iodine 123, you can inject up to 400 megabecquerels. You normally scan for 24 hours, but a 24-hour scan is the most useful. And again, you can do SPECT or SPECT-CT. And remembering that around about 10% of pheochromocytomas can be a bit nasty. Most of them are benign, but there's the rule of 10%. So 10% are malignant, 10% are bilateral, 10% are ectopic, 10% are found in children, 10% are associated with a syndrome such as MEN2, and 10% will be negative on an MIBG scan. And we now know that's because they have a certain gene called succinate dehydrogenase B and D, and those are positive on dotatate, gallium-68 dotatate scanning. So this is a patient with a malignant pheochromocytoma. They got a large tumor which was removed, but 3 months later they've got some recurrent tumor in the bed which needs to be treated either surgically or with iodine 131 MIBG. And this is the SPECT-CT of the same patient, and you see it localizes very nicely to where that pheochromocytoma was. The surgical bed, there's some recurrence. C11 methionine is a very good agent for looking for endocrine tumors. Again, fluorinated products such as FET or FLT may be quite good, but fluorocyclovine may be the better agent for these. And we are investigating that because as PSMA is used instead of fluorocyclovine in prostate cancer, the manufacturer is looking for new ways to use it. And the reason it's good is that it's related to cell growth, but not metabolism. So you're looking at cells of higher cell growth turnover, and this includes adenomas. But then there's no uptake in some organs like the brain because their brain isn't growing anymore. And as a consequence, you get a good target to background ratio. And so we use it for some brain tumors, and that can include pituitary tumors, which are endocrine. So pituitary tumors are either productive, producing TSH, you get a thyroid disease, ACTH, you get Cushing's, and growth hormones, you get acromegaly, growth hormone being the most common. But about 50% are non-productive, and then what you get is destruction of cells producing these hormones. You get a deficiency syndrome. And the treatment is they operate through the nose, the back of the nose, to remove the tumor. However, even doing that, some patients get some persistent symptoms. So do they have residual disease? And that's where we come in. Normally you do MRIs. This patient's had a bit of their pituitary removed. The question is there a tumor sitting there? And it actually can be very difficult to find. So this is where it's useful to do C11 methionine. So here we have the MR, the same patient's CT. Now, obviously, you don't see the brain secreting CT. And here we have the C11 methionine, and you can see at the top and the edge of where they've operated, both here and here, there's uptake of the C11 methionine. So they've left quite a lot of residual tumor behind, and this patient needs to be reoperated. And then that was confirmed in a paper from Brussels, showing that with MR, you find around about 2/3 of these patients, but you find almost every single one with methionine PET. So that's our morning's little trip through nuclear medicine and endocrinology, and remembering that's where we started. And because endocrinology is to do with function, it's very well suited to nuclear medicine. So even though people claim they can do fancy stuff with ultrasound and MR, it doesn't tell you how things are functioning. For that, we need nuclear medicine. And because we do have some very specific tracers that can really help us with getting accurate results and can direct treatment, particularly radionuclide treatment in thyroid disease. And as new tracers come online, particularly PET tracers, we'll find that they probably also have a role in nuclear medicine and endocrinology and can expand what we can do with these agents. So that, I think, as they say, is that. So I've got to try and stop the stop sharing and stop recording.